Thank you. Welcome. Today we have Dr. Kristopher Kahle with us audio by phone. He's driving down to do some other important work. So I'm really thankful that you were able to make the time to be able to do this, Dr. Kahle. Today I just wanted to start by having you introduce yourself. I know you're a little special in that you're a physician scientist, which I'm really happy about. And I know we spoke about that a little bit earlier. But can you maybe start by describing why you're interested in CSF disorders, Chiari related conditions, and how you got involved in this type of treatment and clinical research?
Yeah, thanks a lot, Caitlin, for this opportunity to interface with all your patients through your outstanding organization. I'm currently up at Mass General. I'm the chief of the Pediatric Neurosurgery service. But being a pediatric neurosurgeon in a general hospital, in a very large adult general hospital, I'm not only tasked with taking care of kids, but then also adults who have some of the related disorders. And so hydrocephalus and Chiari malformation, Chiari I and Chiari II malformation are just some of the quintessential conditions that I take care of that traverse the age spectrum. And in fact, it's been my experience that some of these conditions, while they're well recognized and properly managed on the pediatric side, that when kids get older, as they do, and head into the transitional age years, and then into the adult land, it becomes a bit of a wilderness, or maybe even a wasteland, in terms of just trying to identify physicians that not only have the expertise to do some of these surgeries, which often get more complicated because they're redo surgeries, or the condition is particularly complex, or changes with age, but also have a passion to do it. And so I've just recognized a huge need for helping out our older patients who have these conditions as well. So that's on the clinical side. And as you said, I'm a physician scientist. I've been, from a faculty standpoint, down at Yale and up at Harvard. And so if you're in these sorts of environments, I think the expectation is not only are you trying to take great care of patients from a clinical side, but we're here to also to identify gaps in knowledge and to fill them by investigation. And so that's another huge passion of mine. I have a PhD in genetics, and use genomic, human genetic and integrated genomic approaches to elucidate the genetic drivers of some of the conditions that I treat in the operating room. And of course, hydrocephalus and Chiari are the big ones.
That's awesome. Yeah, thank you so much. And I know your focus in genetics is really timely right now because there's a lot coming out about Chiari and the genetic predispositions. At least some of the potential candidate genes that they're finding might be involved, and assuming it's going to be multi um, factorial with the different genes that they're probably going to end up seeing being related. But that will be really helpful moving forward, I think, in helping to determine really who's at risk here, I think. So we have a bunch of questions that came in ahead of time, and I'm going to get to them. And I want to start with one that just really fascinated me. I never thought about it at all, and I'm curious what you think about it. There was a question that says, does caffeine play a role in CSF production? And I know you do a lot of work with hydrocephalus as well, so I'm curious to see what you think about that.
That's a fascinating question too, and to be honest with you, not a lot is known about that. The thing that's fascinating about the scientific literature on CSF production are some of the best and most well-controlled experiments were done decades ago. even by neurosurgeons, and then extrapolated into other model systems like the frog or the rabbit. And the intersection with the nervous system and choroid plexus mediated CSF secretion is very, very poorly understood. Some folks have shown some data that shows both parasympathetic nervous system and sympathetic nervous system input into the choroid plexus that might modulate the rate of CSF secretion. And if there is an impact on CSF secretion by caffeine, that would probably be one mechanism by which that could potentially happen. One piece of data that has come out recently is this notion that the CSF ventricular system as something of a brain drain or waste clearance system, whether it's by producing more fluid or by removing fluid through the lymphatic system, that this system is more active at night. And so during sleep in particular, it's been shown that it appears to be a potential increase in CSF production, increased CSF clearance rate, and therefore I'm wondering if caffeine could potentially antagonize that clearance process by decreasing the quality or quantity of sleep. So long-winded way of saying we don't know exactly, but some interesting tie-ins between the nervous system and CSF secretion on the one hand, and on the other hand, the utility of sleep and CSF clearance.
Yeah, that's fascinating. And I know a lot's being learned about the lymphatic system now, so that would be really cool to study in the future for sure. Um, I actually got a separate question that came in a little later about, and they both have to do with stroke. So I can one of them says, can a CSF leak or cervical, like compression of the cervical spine area, cause any kind of palsies or stroke? And then there was a separate question asking about any potential connections between headache and stroke. And I know that's a big concern, especially for the adults that we see. Their risk of stroke in the future. And I wonder if you can speak to that a little.
What was the first question, Caitlin?
Sorry.
About stroke? It's about stroke and cranial nerve palsies.
Yes. So CSF leak and like brainstem compression, the cervical area.
Okay.
Palsy and stroke.
All right. So we'll take that one first. I think that stroke is honestly, it's a bit of a confusing word, and it can denote several different things. I think what I'm interpreting in this question is stroke being synonymous with a neurologic deficit, which could potentially manifest, therefore, as like a cranial nerve palsy, like a sixth nerve palsy, and so, or at least that's how I'm understanding it, and how I'll answer the question. So I think the idea of could a CSF leak lead to a neurologic deficit similar to a stroke? Absolutely. So we'd see all the time, in the context of different sorts of CSF leaks, whether it's otorrhea through the ear, rhinorrhea through the nose, internally after a lumbar puncture, or an epidural, during childbirth. There can be, for example, CSF leak. I'm thinking of a couple active patients that I have right now that I've inherited from some other hospitals who have had significant CSF leaks internally associated with epidurals that have caused so-called secondary or acquired Chiari malformation, because what that internal CSF leak does is it creates a pressure gradient from the cranium to the spine. And so especially if you're spending any time upright, as most biped humans do, you're going to have an increased pressure gradient that causes secondary cerebellar tonsillar herniation. And, one of the key characteristics of Chiari malformation. That leads to posterior fossa crowding, and that puts pressure anteriorly on the brainstem and the associated cranial nerve nuclei and nerves that emanate from those nuclei to various muscles, including the face or the extraocular muscles. So absolutely, there can, a sixth nerve palsy, for example, can be a harbinger of either a CSF leak or, on the other hand, increased intracranial pressure through, different mechanisms where there's, increased pressure on the nerve, and because of the course, of the sixth nerve, it makes it particularly susceptible to changes in pressure, either low, as experienced during a CSF leak, or high, as you would experience in intracranial hypertension or hydrocephalus or anything like that. So yes, neurologic deficit, cranial nerve deficit, as being one example, could absolutely arise from a CSF leak.
Sure. Before we go on to the second question, can you define the difference between stroke and neurological deficit in that sense? I guess that would
Yeah,
probably be. Yeah.
yeah, absolutely. So stroke is really like I said, a challenging word that gives meaning of which is a neurologic deficit that classically would be associated or due to either ischemia or hemorrhage. And of course, those are the two most common causes of stroke. So hemorrhage, bleeding into the brain, and it's easy to understand why there would be a neurologic, deficit, depending on where that hemorrhage is. And on the other hand, ischemia, which just doesn't mean, which simply means not getting enough blood and associated, oxygen and nutrients to a particular brain area. Depending on the anatomy of the vasculature that's compromised, and therefore leading to ischemia, then you can also have a neurologic dysfunction leading to a weakness or changes in sensation or even changes in consciousness. So stroke would be the outward clinical manifestation of a either hemorrhagic or ischemic event that either temporarily or irreversibly causes damage and deficit.
That's very helpful, and I think it leads into the follow-up about a potential connection between headache and stroke, and I think it's almost a little too vague the way the questions
Yeah,
kind of.
yeah, a little too vague, but so I'm interpreting it again. I can only hearing questions like these from patients, which to me are so good and intuitive, and without a given the complicated nature of the definitions and the nomenclature, it's so easy to get confused, and it's confusing to me, confusing to everybody, frankly. So I think being specific about the definitions and everything is very important, and so I think in this case, I think the question is probably being generated from the fact, like, I have headaches or I have a migraine syndrome. Does that put me at increased risk of future stroke? And this is a literature that the neurologists would know better, certainly a lot better than me. But both migraines and stroke are vascular, can be considered vascular conditions. So there may be some underlying predispositions. I don't know in particular if there's an increased risk of stroke in people who have migraines. I do know that there are certain sorts of migraines that can cause vasospasm and temporary, and sometimes, most often irreversible neurologic deficits, like hemiplegic migraine. It's a very striking disorder. But on the other hand, headaches can, especially the worst headache of life, can be a manifestation of an acute stroke, especially hemorrhagic stroke, or that's one of the first manifestations. So just, most importantly would be just the idea to know that if, you're experiencing what you would consider the worst headache of your life, that could, be a harbinger that you're in the process of a potential, stroke syndrome, like a hemorrhagic stroke or aneurysmal subarachnoid hemorrhage, things like this.
Sure. I want to ask this question particularly because you're interested in CSF dynamics, but how does the cardiac cycle interact with cerebrospinal fluid? And is that something that has to be considered when you think about treating a Chiari with a decompression or hydrocephalus?
That's a great question. And in fact, I would say over the last few years, including work driven by, one of my colleagues at Mass General, Bill Butler, who's really interested in the idea of AV coupling, the idea that with every beat of the heart, every volume of blood that's propelled through the vasculature from the heart to the brain, there has to be first of all, a dampening mechanism to handle that pressure with which it comes to the brain. And secondarily, there has to be an equivalent return of blood from the brain to the heart so that there isn't, for example, increased congestion of the brain tissue and an associated increase in intracranial pressure, which would occur because the brain is housed in the rigid confines of the skull. And so the idea that there has to be an absolute precise regulatory mechanism between what comes in, what comes out in terms of blood volume to and from the brain is absolutely spot on. And so we know, for example, in certain sorts of hydrocephalus and also in Chiari, that sort of AV coupling mechanism can be compromised. And so, for example, a classic example would be some forms of what we term as idiopathic intracranial hypertension, which upon further evaluation, when you do a correct workup, for example, using magnetic resonance imaging of the venous system via an MRV, you realize that, wow, this person is having increased intracranial pressure because they have a relative mismatch in the blood that's being pumped to their brain and what's being returned, because their venous system is either atretic, meaning it hasn't developed properly and is abnormally stenosed or narrowed, or there's an acquired event which further causes stenosis, such as venous sinus thrombosis, which can occur in the context of intense dehydration, or if you're on oral contraceptives. There's a whole battery of things that can lower the threshold for developing a clot. And if it occurs in the venous system, you can't return that blood that's pumped to the brain out from the brain in the way that it should. And so that's the downside. The plus side is that you can actually see in real time how normal cardiac pulsatility is restored to the central nervous system by making a communication from one anatomic chamber to the next. For example, by endoscopic third ventriculostomy, where one of the most satisfying procedures I do, and they only take about 15 or 20 minutes, is by doing an ETV, where after you make that fenestration or window from the third ventricle to the prepontine subarachnoid space, you can actually see CSF flow currents and cardiac pulsatility completely different and in a normal restored way by simply doing that procedure and bypassing the functional or anatomic obstruction for which the patient was taken to the OR in the first place. So cardiac pulsatility, under-recognized contributions to the pathophysiology of these diseases. And and a lot of upside on the treatment perspective by in regard to this theme, because a lot of patients that previously we've been treating with ventricular peritoneal shunts for pseudotumor cerebri or idiopathic intracranial hypertension, are now being taken to the endovascular suite and treated with stents to open up their venous sinuses and thereby restoring CSF dynamics in a secondary way. So yeah, understudied, not fully appreciated, but when recognized, it can be a life-changing event. You give somebody essentially a cure with an endovascular stent versus kind of a lifelong treatment that requires maintenance with the VP shunt.
Yeah. Actually, one of the questions that we had, it's a little bit longer, but it talks about stenting. So it's a 16-year-old undergoing a third decompression. Um, and they said that they wanted to place a stent in the fourth ventricle because the syrinx was increasing even after the decompression. So the question really was, are stents commonly needed, and uh, does that resolve a persistent syrinx like that?
Yeah, so great question. That is a different sort of stent. That's not an endovascular stent.
Sure.
This is a stent. I mean, it's just really using the idea of stent as something that maintains the patency or openness of any channel. And so, while on the one hand, in endovascular stent placed by, for example, one of my colleagues named Kristopher Stapleton in our department, who routinely does this for us. It takes place in one of the major venous sinuses in the brain. The stent that this patient asked their question in regards to, it sounds like a fourth ventricular stent. So that's the fourth ventricle outlet. There's two of them. There's a midline aperture called the foramen magendi, and then there's two out more lateral in the fourth ventricle called the foramen malushka. And so sometimes these can get scarred down and therefore narrowed. And in someone who's had multiple Chiari operations and the associated inflammation that takes place with each one, that happens. I've seen it. And so it sounds like this sort of stent can help maintain the patency of the communication from the fourth ventricle to outside the fourth ventricle. And by doing that, yes, that very well could address the syrinx within the spinal cord, which we do know tends to get better when the CSF roots are patent and transpiring normally. The stents are really made using a little piece of catheter, which is hardware, of course, and I would say subject to all the limitations that are inherent to devices or hardware elements, meaning that they can move, they can get infected, they can get clogged, they can anybody who has a shunt and is listening to me knows what I'm talking about, unfortunately. And that's why we really try to use as best as we can ways to create these conduits or channels by exploiting normal anatomy, or something like a ETV, where you're not putting in any hardware, you're just creating a new channel. And but yet stents can be extremely effective, and I hope it's the case for this patient.
No, absolutely. Thank you. Uh, I want to ask two larger umbrella kind of questions before we move into more of the surgical stuff. But because you're trained in genetics, I was hoping you could talk a little bit about what the likelihood of passing something like Chiari onto someone's child is. I mean, I know not a lot's known about that, but what's the likelihood that someone would have to be even concerned about that in the first place?
Yeah, absolutely. So, I mean, the basic answer is that the familial forms of these diseases, meaning um, diseases that result from a single mutation in a gene that's of large effect and is causing the disease, so-called Mendelian inheritance, whether it's autosomal dominant or recessive, is very small. And yet we know it's in the literature. We have a bunch of patients ourselves. We have the biggest, the world's biggest cohorts right now for both Chiari I malformation and congenital hydrocephalus. So we've collected multiple families that have more than one family member with either congenital hydrocephalus or Chiari malformation, or I'm thinking of somebody that we just had in the office a couple of days ago who has both, and has multiple family members that we just sent for sequencing. So that is more of a rare phenomenon. And so if you take a look at probably the most common familial form of disease, multiple family members, multi-generational, things like, L1-CAM or L1 syndrome, which is associated with X-linked form of hydrocephalus, that presents early in boys and has associated other neurologic, neurodevelopmental disorders, both anatomic and functional. It's really only accounting for like maybe 3 or 5% of folks. But there's another mechanism, another genetic mechanism called de novo mutation, and that's much more common. And that we're beginning to realize that the more patients that we study. So a classic patient that might have a de novo mutation would be somebody that is a sporadic case where the mom is fine, dad is fine, no family history, and then all of a sudden they have a child, and the child may either usually these sorts of cases present earlier in the age spectrum, so maybe presenting in childhood, sometimes with associated other um, neural developmental disorders or autism. Maybe there's something else that gets picked up on an MRI, not necessarily syndromic in the sense of multiple organ systems being involved, but it's kind of what I call Hydro plus or Chiari plus, where you've got the structural brain disorder, the Chiari malformation or congenital hydrocephalus, plus some other thing that whether it's epilepsy, whether it's a developmental delay ranging from mild to severe, maybe there's some eye findings or neurobehavioral disturbances. These sorts of sporadic cases, by sequencing very large cohorts of what we call trios, mom, dad, and then the affected patient, we found, and others have demonstrated, that about 20 to almost 30% of these folks, their condition can be, explained by a so-called de novo mutation that occurs, sometime, in the sperm or the egg after, it's not inherited from mom or dad per se, but it's in the developing, embryo, fetus, and then ultimately, of course, their child. So now that mutation, if the child is able to, survive and have a family and have their own children, that mutation can be transmitted to the next generation. Often, many of these kids can be quite sick and may not get the chance to do that. But other milder forms of disease can, and so that's that accounts for a larger percentage of cases, the so-called de novo mutation event.
Sure. That was really helpful. Thank you. Um, that was a good explanation of the genetics of it all. So that helps, I think, at least put some patients at ease, or parents rather, about whether or not they.
Yeah, I would say that again, now we're talking about forms of, there are, I think taking one little step back that may be useful is just this, this idea in medicine of breaking these conditions down between primary and secondary forms. Secondary forms essentially are those forms of disease in which we have a clear acquired explanation for. For example, I have a Chiari because I had an epidural during childbirth, and I had a CSF leak, and now my cerebellar tonsils are lying lower than usual, and I've developed symptoms. That'd be a great example of a secondary or acquired Chiari malformation. There's no point in doing genetics in that scenario because it's an event that has a identified trigger that is non-genetic by definition. So, but in contrast, and then we all know, and this may, it may be a larger number of patients, at least for Chiari, there are these primary forms where you say, well, I didn't have any, not that I know of. I haven't had a lumbar puncture. I haven't had an epidural. I haven't, any known environmental exposure or anything like that. But yet I have that. And then, wow, this presented at a very young age. These are so-called primary developmental, often genetic forms that, for which, I would strongly suggest, and this is, not necessarily controversial, but so new that I think our field is getting used to this idea. And of course, again, I think part of the issue is that, folks with a Chiari and Hydro, they're kind of largely managed by neurosurgeons. And so, the idea of sending patients for genetic testing is not something that I think neurosurgeons are certainly not trained to do, and often, are either just busy thinking about the main symptoms, or in cases of hydrocephalus, just survival, frankly, especially in acute presentations or shunt malfunctions, that it's not the first thing that comes to mind. Yet, having that knowledge which could be, easily gleaned by doing things like whole exome sequencing, which you can do now for $150 a person, and identify the potential etiology of the condition, can have real great utility for, understanding why this happened in the first place, understanding this is the potential prognosis going forward. And then, of course, medicine is a great example of, other areas of medicine are just great examples of, if you know the pathophysiology of a condition that can be illuminated in part by the genetics, that can help you treat the condition in a better way. And so, for example, there are a bunch of Chiari patients that have, associated connective tissue disorders, whether it's a defined Ehlers-Danlos gene that has just been undiagnosed or not tested yet, or a whole battery of other conditions that just haven't been, discovered yet because this condition hasn't been tackled systematically in earnest from a genetic standpoint, in which that can alter your decision making about what surgery to employ, right? Whether you do just a suboccipital, craniectomy, or whether or not you might need to use a posterior cervical fusion at the same time, because that particular patient is more susceptible to developing, cranial cervical junction instability, right? Because of the underlying connective tissue disorder. So, the idea of Chiari or congenital hydro not being just one monolithic disease, but thinking of it more as like, I think of Chiari or congenital hydro as being like Baskin Robbins or whatever ice cream shop you can think of. And then you walk into the door and there's 99 different flavors. And some of those flavors are going to be really different from one another. And so the idea that we're not just dealing with one sort of ice cream here, but many, many different flavors, some of which you may not like or are going to be very different from what you anticipated, is a useful scheme to think about these conditions. And so, my lab has really been interested in taking these kind of like general conditions and breaking them apart into subclusters that you can define genetically, that we feel like as we learn more about them, they will help us not only talk to families in a more meaningful way when we talk about prognosis of their child or what they might be able to expect. And then most importantly, perhaps, beyond that is choosing the appropriate, treatments, surgical treatments. And then if you push it even further to say, well, you know what, stuff that we're learning, it may suggest that there are even some types of conditions that we think we're doing the right thing by offering surgery, where we might not, and we actually might be hurting somebody by
Right.
doing that. Not of course intentionally. Everyone's got the same goal of trying to get people better, but we're only using the best tools that we have at our disposal, and which are limited by admittedly got a limited toolbox, and the fact is that we kind of have like every time we see a nail, we use our hammer to strike it, and maybe sometimes we shouldn't be doing that.
Yeah, no, that's a really, really good point. Um, and I know that's something that our organization is really interested in trying to figure out too, because it does seem like it's going to be a bunch of different subgroups, quote unquote, of patients that may or may not need surgery and need something else. Um, there are a couple more questions I do want to get to, so we can hopefully get through them quickly. But this one says, why would new symptoms such as paralysis suddenly appear after I've already been dealing with syringomyelia for 3 years? Someone is experiencing paralysis on the left suddenly after 3 years of having a syrinx.
Can you say that again?
Sure. So this patient was experiencing syringomyelia. Presumably, they had some sort of symptoms, but it wasn't that bad. Didn't have any surgery, and then suddenly, 3 years later, there's a sudden onset of like paralysis on the left side, on the face down to the shoulder.
Okay. Well, again, kind of impossible to know without knowing the full history and having any imaging details. But I think the assumption here is it's somehow related to what happened 3 years ago. I don't know if that's the case. If it's something that is related to either a progression of the syrinx, then presumably from the anatomy and the phenotype described, it would have had to extend both rostrally towards the head and potentially caudally, and make the syrinx bigger. So so in this situation, if there was an acute neurologic deficit, or subacute, depending on how it presented, you would need full craniospinal imaging. And one concern would be either a recrudescence, but what sounds like beyond recrudescence, maybe expansion and further progression of the underlying syrinx.
Mm, okay. Is it known what might cause something like that? Pathophysiology kind of speaking?
Yeah, I mean, absolutely. So, for example, if the patient had a Chiari and a shunt because of associated intracranial hypertension, maybe the shunt stopped working. All right, that would be one cause. Or maybe there's been the development of scar tissue, which now, creates essentially, recrudesces the posterior fossa crowding. So it would either be treatment failure, potential treatment failure by, rescarring of pathways in the posterior fossa, or if the patient was treated with the shunt, it can be a presentation of shunt malfunction.
Okay, yeah, that's helpful. Um, this was interesting. Do you think that patients who've experienced pain for a longer period of time might be harder to treat effectively with surgery? And if so, why might that be?
One more time.
So patients who've been experiencing pain for a longer period of time, are they
Yeah.
hard to treat with surgery? And if so, what's the reason behind that potentially?
Yeah, I mean, it depends what again, pain is an incredibly complex, phenotype syndrome. So I'm not sure if we're talking about, tussive headache pain. If we're talking about neuropathic pain, those mechanisms are completely different. And so I would say if you had someone who maybe they've just been experiencing bad headache pain for their whole life. And this is a common story, by the way. They've attributed it to migraines, or their doctors have attributed it to migraines more often than not. And then all of a sudden, for whatever reason, maybe you just hit critical mass, or they end up getting imaging for another reason. They discover, wow, I've got a 15 millimeter Chiari I in syrinx, and this is explanatory for my symptoms my whole life. Maybe this is a 40-year-old patient that now finally comes to attention. And again, this happens all the time. I'm telling you from personal experience. Then I would say, wow, the chances of that pain improving are really good, despite the fact that quote unquote pain has been their whole life. Why? Because it's a anatomic, it has a clear anatomic driver that has not yet been addressed. So
Hmm.
that's great. And then I would say the other end of the spectrum, the other end of the continuum would be, the person who's been operated on a few times and maybe has developed pain from occipital neuralgia, from, just a neuropathic pain syndrome, maybe from the operation itself. That's unlikely to get better with another surgery. In fact, it could get exacerbated by it. And, those sorts of, that sort of pain spectrum is better dealt with, with the help of our pain specialists who are really good at treating neuropathic pain. So, drugs like Neurontin or gabapentin. And then there's, dr- advances in neuropathic pain management, I feel like are coming out daily. So, I would say that's a completely different mechanism. So it's important to define not only the duration of the pain, but what the pathophysiology of the pain is, because that'll get you triaged appropriately to a specific treatment.
Perfect. Um, and then I'm going to just do two more questions for your time. And then one was, what's your general approach to a Chiari patient that has cervical syrinx but seems to be asymptomatic and has normal neurological exam? So they say here greater than 6 millimeters, I guess, in diameter. Is that something that needs to be dealt with? So there's a syrinx in the cervical area, but presumably no symptoms are really bothering them.
Yeah, yeah. I think in those situations, I guess the question is why did the patient get imaging in the first place? But if it's incidental, so-called incidentally discovered, maybe they were in a car accident, or they hit, had a concussion playing soccer or something like that, and it's truly incidentally discovered. I think that there might be some uh, debate if they're clearly, completely asymptomatic. But our field's guidelines, and I think any neurosurgeon, if there was a evidence of a Chiari I malformation and associated flow disturbance that you might be able to detect with cine flow imaging, for example, in the presence of a syrinx, that even without symptoms, it should be addressed surgically. And the reason for that is because we do know from natural history studies, from patients who present later, that once you that presence of a syrinx, and I'm talking about a legit syrinx, like you said, you mentioned 6 millimeters, but I'm not talking about 1 to 2 millimeter quote unquote syrinx that may be just a vestige of a central canal and non-pathophysiologic, right? That's a critical distinction. But based on diameter, and if it's a legit syrinx, then I would say that the patient should probably go to surgery even without neurologic symptoms, because that syrinx is really a harbinger of downstream likely neurologic dysfunction, and you're just catching it. It's an opportunity. I would think of it that way, for catching something early before neurologic symptoms set in when it might be too late. And so I would take that. I would take the identification of a legitimate syrinx and very seriously. Talk with your neurosurgeon. And I think most folks would probably offer neurosurgery in that context. I mean, it should be, folks should be reminded. It seems very obvious, but in these situations, it's not like a ruptured aneurysm or a malignant brain tumor where the neurosurgeon will say, hey, we really need to do this now, or this is you're not going to be here tomorrow. Okay, there are those situations, and this is obviously not one of them. And so it's elective by definition, meaning you can schedule it. That doesn't mean it's not serious. But in some sense, that elective nature where you do have autonomy, right? You can say, no, that's not what I'm going to do. That's not how I want to treat this. As long as there's clear understanding of the ramifications of that and the potential, the risks, the benefits, and alternatives to surgery, these are great discussions to have in a thoughtful way. It's great to get, second or third opinions, about these sorts of things. But presence of a syrinx along with the Chiari I malformation is I would call it a radiographic indicator for offering a surgery.
Perfect. Yeah. No, that's a really good point. And then I'm going to combine these two questions because they ask similar, really, question. So for someone who's not a candidate for surgery and someone who may have already had surgery and now is symptomatic, should they have another surgery? But wow, not making sense. So someone who's not a candidate for surgery or someone who's already had surgery and maybe doesn't want to get the surgery again, what are the other options other than surgical intervention for Chiari or syringomyelia specifically?
Yeah, so the question of non-surgical treatments for Chiari I malformation, again, there's a lot of stuff that that needs to be parsed out here in terms of etiology of the condition, and of course what the associated symptoms that the patient is having. So we do know that as we're collecting patient cohorts and these sorts of subtypes of these of Chiari are being described, is that there are a lot of associated symptoms, right? Whether it is anxiety, some psychiatric conditions, connective tissue, diseases, postural instability, imbalance, migraine. There are a bunch of things that we know that are clustering with Chiari I malformation that cannot be simply explained by chance alone. And so it's a phenotypic cluster, or what we would call endophenotypes, different sorts of things that are associated with Chiari I malformation. And so the idea of, okay, what can I do for myself to help out beyond having surgery? Well, you could take each one of those associated symptoms one by one and systematically think about who are those specialists and what do they bring to the table to help me, maybe not get rid of my symptoms, but either manage them or ameliorate them. And so whether it's, thinking about Chiari not as not just a neurosurgical disease, but something that should be taken care of in a multidisciplinary way with and this is of course what we try to do at MGH and a lot of other great institutions, like WashU or Hopkins. I mean, there's a lot of great places that do this, in which you're saying, okay, my patient, that I may or may not operate on, in addition to what I bring to the table as a neurosurgeon, needs a really good psychiatrist. They need a really good rheumatologist. They need a good neurologist. Having people come together, and their specialties by definition are non-surgical. It doesn't mean there may be procedures, but not neurosurgery that could really make things better. And our pain colleagues do a great job in helping us help manage patients and bringing to the table just kind of a battery of different techniques, medications, resources that can make the patient's experience better without necessarily having a big suboccipital decompression. And so fundamental to a lot of the drivers of Chiari I malformation are anatomic, right? So that's for neurosurgeons, that's what we do, and that's within our wheelhouse. But I think the problem is and I think we've come to realize this, is that, okay, you have a patient presenting with a headache that really gets exacerbated by coughing or sneezing, and maybe some numbness and tingling in your fingertips, maybe some imbalance issues. But in addition to that, there's generalized anxiety. There may be postural instability. There may be a whole bunch of other things. And you do the surgery, and yeah, great, doc, you fixed my headache, but I've got all this other stuff that remains. Why didn't that get better? And so I think that just says something to, number one, the complexity of the disease, two, how little we know about it and the need for continued research, three, an illustration of why multidisciplinary care is important, and then four, having great discussions with your neurosurgeon, before the operation takes place, about what can I reasonably expect to get better, given all the complaints that I just talked to you about.
Exactly.
And so those need to be, and of course, we don't always know we don't know the answer a lot of the time, but we can say, okay, of the list of the 5 things that you just said, these are the most specific symptoms that are related to this anatomical impediment that I'm going to address during surgery. And therefore, I feel, in my range of confidence level, pretty good about you getting better in regard to your pussive headache. But I don't know what that's going to do to, some of the brain fog issues or postural instability issues. Now, don't get me wrong. Sometimes and often those can improve too with surgery. But I would say my confidence, just because we don't understand it as well,
Right.
Of how those symptoms are going to react to what we do, in the operating room, is less clear.
Yeah, they still don't really, they're learning what the cerebellum and that whole area of the brain even does. I think anyone who says they fully understand the brain is delusional a little bit. So,
Oh no doubt about it. And there's cool work. Again, it's the great part of being part of an enterprise in at Mass General, where my colleagues Bill Butler, Sid Cash, Jeremy Schwammen, one of the world's biggest experts in the cerebellum. We've really teamed up at monitoring cerebellar function for those who want to get involved in our studies, in the operating room, where we say, okay, yeah, we're not only going to perform the surgery that a lot of different people can do, but simultaneously try to understand or use that as an opportunity, without altering anything about the surgery that we do, or adding extra time or anything like that, to figure out how these potential poorly understood cerebellar circuits are, impacting things like cognition or even speech, um, and other things. So yeah, it's a really fascinating time to be working on this kind of stuff because of some of the technological advances that are allowing us to measure things that we didn't even know existed before.
Yeah, that's fascinating. Yeah, that's really, really cool that you guys can do that. Especially if it's like it's just for learning and it's not changing the surgery at all. That's great for a lot of people that would be interested in participating in that kind of research. Um, but to that point, actually, this is a great segue. How can people get in touch with you if they wanted to see you? Do you see just peds or do you see adults too? I think we talked about that a little bit before coming online. Um, and how can people get in touch?
Yeah, I mean, so as my wife would remind me when I ask her for a question, she says just Google it, and it'll come right up. So yeah, my name is Chris, spelled with a K, K-R-I-S, Kristopher, and my last name is pronounced Kahle, K-A-H-L-E, and I'm up at Mass General. So if you type in Kristopher Kahle, Mass General, you'll see my office number. I've got a great, outstanding staff. Um, Diane is my, assistant for pediatric patients, and yes, absolutely, I take care of a transitional age and adult patients. Mel is my adult coordinator, and I've got a great partner, and we work on our approach to Chiari, Bill Butler, who's famous in his own right, and just a tremendous colleague. Um, at Mass General, we think deeply about this stuff, and we often discuss, our patients together. We have a really, big multidisciplinary program. I can't name each person, that is part of the program because it would take, probably 10 minutes. But so that's the clinical arm of things, and yeah, we're always, you know, open for business, love to talk, even if it's just giving our thought about a case or a second or third opinion, as happens quite frequently when you're a big city like Boston on the East Coast. That's the clinical arm, and then the scientific arm or the investigative arm is you can check it out at kahlelab.com. On that site, you can click and get involved in a study. If you got on there, after hearing this and put in your information, you would probably have a FedEx package at your door within a couple of weeks with instructions of how to get involved in one of our genetics studies, and yeah, we're all in on not only Chiari but other cerebrospinal fluid related disorders like hydrocephalus, cysts, developmental conditions. Like I said before, we recognize I would say my passion is kids and children, but it's been incredibly gratifying to now take on this additional endeavor of treating transitional age in adult patients, because there's a huge need. There's a huge need. Kids with developmental disorders get older, and
Yeah,
when they get older, they definitely get hung out to dry because these are fundamentally developmental or quote unquote pediatric neurosurgical conditions. But
yeah,
then when they graduate from the pediatric hospitals, the standalone pediatric hospitals, where a lot of kids are getting moved out after they're 18 years old, and of course that's right around the time of life where a lot of things are going on, and if you have a developmental disorder and you're not, depending on the home life, or you might not have a job, like things can get dicey very fast. And so I would say it's an incredibly vulnerable period of life where a lot of kids get lost to follow up, and that's when that's when bad stuff happens. And
Yeah.
so, whether it's kids, transitional age, which, I never know how to define, but, it's that age where, you know, you see if you're healthy, you think you're invincible until you find out that you're not, or if you have a developmental condition and you move out of the house or into a group home, or something happens to your caregivers, you're really it becomes bad pretty fast. So
Yeah.
happy to take care of essentially any patient.
Yeah. And I feel strongly about that too, because then really what's happening, because they are lost to that follow up, that it seems like everything's going great in the pediatric world, but once they get to be adults, it's just like I know they find us after a certain point, and it just gets really hard to help direct. So I'm really happy that you um, are working with that age group and kind of helping them move into adulthood in a way that is meaningful. That's really, really important. Um, all right. Well, I don't want to take up too much of your time because we went over more than I thought we would. I'm sorry about that. But thank you so much, Dr. Kahle, for talking with us today, going through some questions. And I know I'm looking forward to reaching out to you again in the future.
All right, Caitlin, thanks for the opportunity. Yeah, and I wasn't even looking at the clock. As you could tell, probably from how fast I was talking and how long we talked, I'm extremely passionate about this stuff, and I could go on and on. So I'm sorry for keeping you all for.
Oh, no, I felt bad for you. I know you have places to be. Thank you.
All right, we'll talk to you later, Caitlin. Thanks a lot.
Absolutely. Safe travels. Thank you.
Bye bye.
Bye.